Dr. Eber. Joining us next is Dr. Lauren Bealey. She is the Antimicrobial Stewardship Pharmacy Lead at Colorado Department of Public Health and Environment. Her work is really vital to our state. She focuses on improving antibiotic use and tackling antimicrobial resistance across the healthcare spectrum. With her deep background in diagnostic stewardship, she is perfectly positioned to lead today's session. And so we are thrilled to have her here to provide a comparative look at urinary diagnostics. So let's welcome Dr. Bealey.
Hi, everyone. Thank you so much for joining today. As she said, my name is Lauren Bealey, and I am thrilled to be talking about urinary diagnostics. I was going to call this, you're in for a great afternoon, but I thought I would try to minimize the puns. All right, so today we're going to be talking about urinary diagnostics in the nursing home setting, comparing molecular diagnostics, which I'll refer to as PCR for polymerase chain reaction, or next-generation sequencing, and we'll compare those to traditional culture and sensitivity, as well as applying principles of antimicrobial and diagnostic stewardship to the nursing home setting. I love history, so I wanted to look back for how long we've been examining urine, and it turns out over 6,000 years. That's amazing. There's actually clay tablets talking about urine. So there's no excretion that possesses more interest than the urine. And so, anyway, this is an ancient picture of at some point. And so the question really is, how do urine diagnostics affect the care of nursing home residents today? Because we're obviously still doing it. So there are some certainly challenges, particularly in the nursing home setting, when it comes to diagnosis, difficulty communicating symptoms, comorbidities with symptoms that can overlap the symptoms of UTI, cloudy urine. We already touched on falls today and frailty. Then when you move into risk factors, I'll be talking a little bit about the risk factors of acquiring an MDRO or a multi-drug resistant organism, hospitalization and healthcare exposure, invasive devices and catheters. And then when it comes to antibiotic use, there becomes a problem with things like antibiotics used for asymptomatic bacteriuria, fluoroquinolones, and extended prophylaxis. So we know that up to 70% of nursing home residents receive antibiotics during a year, and up to 75% of those may be inappropriate. I have some updated data for you here that nearly 10% of nursing home residents receive an antibiotic on any given day. So it's a huge amount of patients receiving antibiotics, and about a quarter of them have an antibiotic-resistant infection already. So that's pretty interesting. We know the greatest contributor is asymptomatic bacteriuria, and just being a resident of a long-term care setting is a risk factor for colonization with multi-drug resistant organisms and C. diff. So because of this, we know that CDC and CMS have identified nursing homes as priority areas for improved antimicrobial stewardship, and I've listed those 7 core elements for you. Asymptomatic bacteriuria, of course, is bacteria recovered from a urine sample without the person having localized urinary tract signs or symptoms. Screening for or treatment of asymptomatic bacteriuria is not recommended in nursing home residents, and that's because the culture can be positive anytime. Anytime you look at it, bacteriuria is present in about 50% of female residents, 40% in male residents, and up to 100% of residents with a chronic catheter. There are times when it is recommended to treat asymptomatic bacteria, but those are very few and far between, things like pregnancy or immediately prior to a urologic procedure. And the reason for that is because when they've looked at treating asymptomatic bacteria in nursing home residents, it's not been shown to improve patient outcomes or prevent hospitalization. But it can lead to unnecessary antibiotics and adverse effects. So I have a couple of cases in here with just things to think about. We have a 76-year-old female nursing home resident who complains of urinary frequency. She was recently started on a new diuretic for heart failure. Her vital signs are stable, her urine's cloudy and has an odor. Her UA is positive for nitrites and leukocyte esterase. And so thinking about the criteria to assess this resident. As we go through several different types of urinary diagnostics today, I wanted to talk about a framework that you can use for any of them, because honestly, with the newer ones that are coming out, the reports all look pretty different. And so I want to have a standardized framework where you could evaluate the reports that are coming back on some of these newer diagnostics, or if you get a culture back too. So the first one is the right patient. Why are we testing? How high is our pretest probability for this resident in having a UTI? Do they have localized urinary symptoms? The second one being the right time. So do they meet lobe criteria? Again, what's that pretest probability? Because if you know that half the time you're going to get a culture back positive, you want to have high pretest probability that the patient actually has an infection. The right test. So as these newer tests are coming out, you want to be thinking about the sensitivity and specificity of these tests. Are they more sensitive than culture? Are they more specific? What do they help us to understand? Additionally, what quantitative data do we have? Because for some of these tests, we don't have things like colony forming units like we have with culture. So what quantitative data are you getting back in your report to help you make a decision? When looking at the bugs, I've seen for some of these reports, there's maybe 4 organisms that come back in a urine or 8 that come back in a skin test. So making sure that you're evaluating, is this organism a common pathogen? And does the result indicate colonization versus infection? And then finally, the right drug, if needed. So if they have a symptomatic UTI in this case, utilizing treatment guidelines and antibiogram to optimize right drug, right dose, right duration. So this is a framework I'll come back to towards the end, but hopefully this is something that can be applied to any diagnostic as it's coming out and you're reviewing the results of that report. So this comes from Dr. Ashraf's paper from 2020 about the definition of UTI syndromes, including asymptomatic bacteriuria, cystitis, catheter-associated UTI. They have the diagnostic findings, recommended treatment, which again, in asymptomatic bacteriuria is no antibiotics, and some notes, some things like fluoroquinolones not being used first line. These are the lobe criteria, just a snapshot of those developed in 2001. It is that minimum criteria for initiating antibiotics in long-term care residents with a possible infection. So I'm sure we're all pretty familiar with these. Without the indwelling catheter, it's that fever and those local urinary symptoms. With an indwelling catheter, again, fever, and there's some more systemic symptoms like new CVA tenderness or rigors. I love this slide from Dr. Robin Jump. She gave a fantastic presentation on the difference in lobe and McGeer criteria. This is something that we do still talk about whenever we talk about stewardship in long-term care. So lobe being used to guide those clinical decisions and initiate antibiotics, thinking about patient care, prospective. It doesn't require lab values, so it can be done at the bedside. Versus McGeer criteria is primarily for surveillance, NHSN reporting, and retrospective. This is one of our tools. I'll talk about some of the tools we have at CDPHE, Suspected UTI Action Tool. Talk about this one a lot. It's supposed to be pretty simple. It's a couple of check boxes, so you can evaluate if the resident has a possible UTI. All right, so now your resident, the only option to order was a PCR. So your urine PCR comes back as E. faecalis, Proteus mirabilis, Pseudomonas, and Staph aureus. So then there's some things to think about is when you get this back, what's your approach to the results? What differences might you have seen on a urine culture versus a PCR? And how would you describe these differences to staff? So those are some questions that I'm hoping to answer in the next few minutes. When looking at the different types of tests, I have here organized as dipstick, urine culture and susceptibility, or molecular diagnostics. A few things to note is that dipstick and urine culture and susceptibility are FDA approved. Molecular diagnostics are not. They're considered laboratory developed tests. When we look at things like urine culture and susceptibility, we get identification and susceptibilities. For molecular diagnostics, we can get identification, and they can do antibiotic resistance genes, but not susceptibility data. So the reports that you get back will look different. For urine culture, it's the gold standard. It's familiar to us as clinical and lab personnel. It can detect slow-growing fastidious pathogens with live aerobic growth. Molecular diagnostics have rapid identification, and they're highly sensitive. So because of that, you're more likely to get polymicrobial results. Urine culture susceptibility does take a longer time, up to 120 hours or more to result, and does not help you distinguish between asymptomatic bacteriuria and infection. That's going to be from symptoms. Molecular diagnostic can provide those resistance genes, does not provide susceptibilities, and again, often one of the big differences that we'll talk about are those polymicrobial results. So here's our urine culture. It's reported in colony-forming units, or CFUs, per ml or liter. The sensitivity is around 90%, specificity is around 89%. We've actually been doing culture since the 1800s, so we're still doing them. And it's combined with antimicrobial susceptibility testing. So I have some examples here of plates that are positive polymicrobial contaminants and negative. Talking about some of the newer tests like molecular diagnostics, these are considered culture independent because you don't need to run a culture with these. PCR is a lab technique that amplifies and detects DNA sequences for identification. Next generation sequencing is going to analyze the complete DNA of the microbe and then compare it to a database to identify it. And some may report the presence of genetic markers indicating potential resistance, but that may vary by test. The sensitivity is high. It can be as high as 100% for bacteria with 96% specificity. They do detect higher rates of things like anaerobic and fastidious organisms because culture typically relies on live aerobic growth, so faster growing organisms. They also tend to identify pathogens sooner. So if you have looked at PCR reports you've seen, they can identify pathogens 43 hours sooner than a urine culture and susceptibility, often within 24 hours. That being said, polymicrobial results are common because of its sensitivity, so up to 29% versus 7% in culture and susceptibility. I love this image. This is from a paper from 2022, so if you're interested in this topic, this is a great overview. And what I like about this is we have Venn diagrams about what's actually growing from these tests. So you have the urine culture in yellow. In the middle is what both tests were able to grow. And on the right are things that were unique to the molecular test. So for A, between urine culture and next generation sequencing, both of them grew E. coli, E. faecalis, and Kleb pneumoniae. But there's quite a bit of difference between what's grown on either side, with urine culture being bugs that we're a little more familiar with. And for next generation sequencing side, it's more some of our anaerobes and things of that nature. Then when comparing urine culture and PCR, in B, we have Candida albicans via culture, ureolyticum via PCR, and then quite a few similar ones in the middle. So some differences in how you can evaluate which pathogens might be coming back in these different types of tests. A couple things about these diagnostics, when they come back, these molecular diagnostics, there is less quantitative data. So you're not going to get CFUs per ml with these tests because it's just not how they're tested. So there's less quantitative data. They may present as copies per ml, so fewer copies, more copies, things like that. But unlike culture, we don't have a way to link this to clinical significance. So we don't have a way, there's no FDA standard of what low, medium, and high means, and so it can vary pretty significantly between tests. Another thing to note is that it cannot distinguish between actively growing organisms and dead or contaminant organisms. So again, that leads to those often polymicrobial results. So for that reason, it can't distinguish what's a colonizer, what's an infection, and if it's an active infection or a prior infection. So all of those things are good things to keep in mind if you're evaluating these results. And so it does have high specificity, but if you have a low pretest probability that your patient has a UTI and you run one of these tests, you certainly risk false positives. Like I mentioned, it's not FDA approved, so there is some lack of consistency with things like report formatting and reference libraries, so just something to note. You're also unable to get susceptibilities, so what you'll see instead is the results of resistance gene testing, not your traditional, MICs with susceptibility like you have with a culture report. It's also a higher cost, and with all the citations I have listed here, it's mentioned that it cannot fully replace urine culture, and I'll talk a little bit about what PALTmed has to say about that as well. So I wanted to mention that if you do come across the PCR result, we see them all the time, that when you're evaluating this, you want to see, do I have quantitative data to help me to determine what could be the causative organism, which resistance genes were tested, and based on the patient and what I'm seeing in the report, do these results tend to indicate colonization or infection? So some important questions to answer when looking at these reports. You also want to think about what are the most likely organisms causing the infection. Are they common urinary pathogens? I also wanted to note, I was looking at one of these earlier this week, and some of these reports will come back with antibiotic recommendations. And so just something to note is that those recommendations are likely to be overly broad because they want to cover every single pathogen. So again, if you come back and have a result with 4 pathogens growing, they're trying to pick antibiotics that cover everything. So maybe ertapenem and linezolid or cefiderocol or something like that. So just to note that that's another reason that you want to really take a close look at what may be causing the infection, because those results that come back are likely trying to cover everything. And then one thing a clinical question that we still don't have an answer to is if we do have a high suspicion for infection and we get back polymicrobial results, should we recollect? And we don't have an answer to that at this point. So we did at CDPHE create a resource that has a comparison. So we made a wall chart with the idea if you just want a one-pager for how to compare urine culture and molecular diagnostics like PCR or NGS. So this is something that you can evaluate with your staff. It goes over how they work, benefits, limitations, and different things, as well as some citations. And then we have a narrative too. So if you want to have some more information, more detail, we have that listed there as well. And that's on our stewardship and long-term care website. I wanted to go over some data that's come out since these other publications around PCR. So CDC, Dr. Hatfield published this study in 2024, where they took a look at the number of carrier claims with procedure codes indicating multiplex tests from 2016 to 2023. And so I know that it's kind of tiny, but the teal bars are urine. So you can kind of see those going straight up from 2016 to 2023. And so Dr. Fitzpatrick has a great editorial in JAMA Network Open about this article. And in it, they talk about that the annual rate of urine multiplex molecular testing increased by over 50 times without a corresponding increase in urine cultures, most pronounced for nursing home residents. The median per claim cost was more than 70 times higher, so around $585 versus $8. And extrapolating that to all of the 460,000 claims in 2023 was $269 million. So highly recommend her editorial. It's really great in talking about these data. A couple of consensus statements have come out recently. One is choosing wisely. So don't obtain urine tests until clinical criteria are met, and don't utilize molecular testing to replace urine culture for diagnosing and determining treatment for urinary tract infection. So that is available on PALTmed as far as choosing wisely. And then most recently is a consensus statement from 2025 by Dr. Zering, is the lead author out of Washington, and Dr. Ashraf from Nebraska. And they came out with a need for a timeout, recommending against the routine use of urine PCR testing for the diagnosis of UTI. I put some quotes in here from the consensus statement. It's quite brief if you want to look at it. That the evidence supporting urine PCR is often biased because of funding sources, and there's no objective evidence of patient benefit. And then the other quote is, urine PCR testing will likely lead to unnecessary antibiotic use, which drives antimicrobial resistance. So pretty strong statement. And again, that is available. They also mentioned that nursing homes should use the CDC's core element framework for engaging with the multidisciplinary team when talking about urine testing. And this consensus statement was endorsed not only by PALTmed, but SHEA, APIC, and the American Association of Post-Acute Care Nursing. Because I included my title, I thought I had to talk about briefs, and they do mention it in the consensus statement. So urine PCR has also been advertised for residents who are unable to give a clean catch sample as an alternative to a straight cath. Just a few things here. It's not endorsed by professional society guidelines. The studies of urine samples from briefs didn't account for things like fecal and skin contamination on sample quality, and there was an increase in false positives noted in 2 studies. So this one is also not recommended per that consensus statement. And just to close, I wanted to talk a little bit about diagnostic stewardship. I love antimicrobial and diagnostic stewardship. Diagnostic stewardship is so important because we now have over 3,000 tests that we can order in patient care. There's just so many. And so we want to optimize the communication, education, and interpretation of test results. When it comes to microbiology, over-testing is the most common type of microbiology diagnostic error, leading to things like overdiagnosis, treatment of contaminants, and increased costs. So I have this slide for you with just some ideas for the 3 phases of diagnostic stewardship, being pre-analytic, analytic, and post-analytic, with some ideas for improving diagnostic stewardship around UTI. So again, first step being evaluating those urinary symptoms, requiring symptoms or an indication for ordering a urine test, making sure samples are properly collected and transported, and then post-analytic, making sure everyone has a good understanding of those lab results, and having some comments around colonization versus infection. So again, that framework that I think you can use for any of these is right patient, right time, right test, right bug, and right drug if you need to treat. And it's not advancing. Oh, there it goes. Okay. And then at CDPHE, I wanted to go over a few other tools that we have on our website if you're interested. We have that UTI action tool. We have an antibiotic timeout checklist if your facility uses timeouts. We have an antibiotic tracking tool where you can put in your starts and it makes graphs and visuals for things like QAPI meetings. And then the last one is the summary of treatment guidelines of common infections. So what we did here is we didn't come up with these guidelines. We summarized the available guidelines through IDSA and others, included the Loeb criteria, and have tables with things like drug, duration, and dosing recommendations. Also, just a plug, I'm sure you may have seen this, but we have an antibiogram for nursing homes from 2023 with data from 196 nursing homes. It's very urine-driven. There were 95% of our culture results were urine, but if you're interested, you can take a look at that as well. And I always like to include a couple of other things when it comes to training and education. So in addition to if you're evaluating a patient for possible asymptomatic bacteriuria, AHRQ has some really nice templates for ordering active monitoring instead of antibiotics. And there are some great UTI communications examples on AHRQ too. These are my favorite. So when helping staff with interacting with family of residents and talking about, some scripting on if the urine is dark and smells bad. Last time a patient was, the doctor prescribed an antibiotic for my family member and he felt better. So some really nice scripts there as well. So in summary, evaluating each urinary diagnostic with those steps, utilizing Loeb criteria and local urine symptoms to treat infection without treating colonization or asymptomatic bacteriuria, evaluating any quantitative results that come back with your report in addition to qualitative, especially if you get polymicrobial results, incorporating some of those diagnostic stewardship strategies, and then noting that the Post-Acute and Long-Term Care Medical Association recommends against the routine use of urine PCR for the diagnosis of UTI. Thank you so much. I'd be happy to take any questions.
One of the frustrating things with the urine PCR testing, molecular testing, is that nursing home chains have sometimes arbitrarily switched to doing it based upon cost charges by labs. And so this is now a couple years ago, a nursing home chain that has a number of buildings in Colorado, not a large number, but a few, chose to sign a lab contract, and that lab brought in the molecular testing. And when you saw the cost data, the $588 average fee is not for a full panel. If you add additional bacteria that they're going to screen for, there's additional costs. So sometimes it can be a multiple of the $588. Keep that in mind. We're talking into thousands of dollars instead of a urine culture. So, and then the second thing is, they were flying the urine samples to Florida, where they were running them through very quickly after a 4-day delay getting them to Florida. So it's kind of, and imagine what happens to the urine in those 4 days. So it was a useless exercise in profit greed by a lab who offered a low rate for lab services just to get the contract. So think about that.
Yeah, thank you for that. We've definitely heard about that as well, as far as those decisions being made. And I just think too, by having things like choosing wisely and the consensus statement, it just adds some weight behind it that we didn't have before 2025. So, I think, again, that's why I say I think that you'll still likely come across these results, and so having the best way to navigate that, in addition to, if you prefer culture, trying to make that change at the facility level as well. But yeah, definitely a great point. Any other questions? I have 40 seconds. I like the timer a lot. It's great. Oh, yes.
Antibiotic to prevent UTIs.
Chronic. Mm-hmm.
Yeah. Is there any
Chronic.
role for that?
That is such a good
I'm
question.
sure there is, but
Yeah.
on a primary care basis.
Yeah, that's a really great question. Thank you for that question. So the role of chronic prophylaxis, kind of like in the COPD talk where she said that was something that was previously done quite a lot. That's something that is done very infrequently, just because the risk of side effects seems to be so outweighing the potential benefit of doing that chronic prophylaxis. So we've really seen a huge decline in that practice of using, low-dose cephalexin, or in particular low-dose nitrofurantoin. Any of those are really we were seeing it less and less compared to old practices. And again, just being able to have an idea for that pre-test probability, does the patient actually have symptoms, and weighing that with the long-term risk of things like C. diff and other side effects. Thank you.
Thank you so much. Okay.